I was a paramedic, started in 1987 after a couple of years post-uni. Loved the job. Started in Sydney. I ended up moving country. To go country I needed to move to Queensland and did nursing. And towards the end of my nursing degree I heard a talk on PAs and went, oh, holy hell, that's what I want to be.
So can you tell me about the Australian healthcare system and the impetus for starting this program here? I mean, why do this here? I mean, who's pushing you? I mean,
yeah, sure. At the time they started fooling with the idea back in the 90s, 1990s, there was a shortage of doctors and there was a very gross misdistribution of health workforce in those underserved areas. So that was the original intention of the people that were really moving towards pushing this. Over the course of time, things changed somewhat, and for a number of different very complicated reasons, we went from a doctor shortage to now an oversupply, especially of medical students and young junior doctors, as they're called here.
Had trouble finding placements. Can you talk about from that when you first started to how you got here?
I went back and was a paramedic for 5 years, waiting, hoping, and eventually one of the JCU students did a placement through here in ED, and once again a doctor who had great foresight went, oh hell, I can see how this would work, and he got some funding for a trial, and there was started with 3 of us. I was lucky enough to be one of those 3, and we're here.
As far as the sort of social side of healthcare goes, it's a very, very conservative system. It's still very doctor-centric. Concepts like team-based healthcare delegation, task substitution are all very, very new concepts here. And some of the more conservative organizations, like the Australian Medical Association, like most of the nurses' organizations, unions, are opposed to us because they see us as a threat one way or another.
So how much are you limited compared to like an American PA?
Yeah. Where 90% our stuff is just taking bloods, ordering, taking bloods, imaging, just that initial stuff. Yeah, people don't know what PAs can do, and until they do, and slowly, Mitch and I are just adding bits, and if you look at the other PAs throughout Australia, that are just, and there's very few doctors that once they've worked with you and figured out what you can do, can't see potential. The light bulb. Oh, you could do this, you could do that. Perfect.
The other problem is that we're only recognized in one state out of 6 states and 2 territories here in Australia to practice in the public healthcare system, and that's Queensland right here. You can see behind us the hospital, the Townsville Hospital, and that is the first place to actually hire PAs here in Queensland. And to give you an idea of the tyranny of distance here in Australia, that is the tertiary medical center between here and Brisbane, which is 900 miles south, and Port Moresby, Papua New Guinea. In fact, we're closer to Port Moresby. So in between are base hospitals, quite a few steps down, and rural hospitals, but that's it. That's the tertiary care center until you get down to our capital, Brisbane. So there's great need in rural and remote areas in Queensland for all the healthcare workforce that you can get a hold of, and that's hopefully where we're going to make our mark.
So tell me a little bit about your backgrounds and starting the program here.
Where do you want to start with?
Alrighty. He realized my frustration and desire to move on. I'd known about PAs, since I was in the Army, and we were out for a beer one November night, and I said, "Yeah, well, next year I'm gonna apply." And he was like, "Next year? What are you waiting for?" And applications were due, in the beginning of December. So I ran around like a madman, got all my letters of reference, records from these different schools I'd been to, turned in my application, got into the course, and rolled from there. So left Illinois and moved back to Utah. And that's where I spent my whole clinical time. I spent about 5 years working at the 4th Street Homeless Clinic. When I first got back to Salt Lake, which at the time was part of the Community Health Center system. And then from there I moved up to the VA Medical Center, and for the next 8 years worked full-time and then part-time at the VA, and then found clinical medicine more than I could handle with my job in academia. So became an academic.
Having practiced as a PA in the Netherlands in a first world setting, and not just in the first world setting, but also in a very what you would call upper class environment in The Hague, where we serviced many embassies and international organizations, in a primary care setting, was very satisfying, very challenging in its own way. But I've been drawn to clinical work in a developing country like South Africa, and so that drew me. And I certainly got a lot of very, very challenging circumstances to work in South Africa, and so that that challenge was great, because it brought out a lot of the skills. The skills that I'd learned but never applied. And the best example was when we were 4 clinicians servicing a 180-bed hospital during a national healthcare strike, where about 90% of the healthcare workers left left the hospital. And so we had to do everything ourselves, and those including radiologists. So your clinical exams had to rely, or your management had to rely on your clinical exams only, where you have to put in a chest strain and trust that you have have examined the patient sufficiently to warrant that procedure.
But thinking about a particular patient, gosh, there was a guy who was, he's a psychotic diabetic, and he was normally cared for by my partner in crime at the time, Fred Bosenthal, who became a great friend of mine, and I just saw him a few months ago in the States too, and he and Fred had a pretty good relationship, but this gentleman came in one day when Fred wasn't there, and he said he was having a problem down there on his feet, and he took his shoe off, pulls his sock off, and all these maggots fall out of his sock. He was right there. Of course, the end of his toe was pretty much gone, and he's got a farm of maggots living on there, which, of course, nowadays we use maggots to clean wounds. But, I had Gene put his shoes back on and leave the maggots right where they were and send him up to the hospital to have that looked at. But, there was pleasure and there was pain in a place like that. A lot of sad stories, a lot of humorous stories like that. You met people who were aged well beyond their actual years because of being homeless or living in such challenged situation. A lot of really sad things that you couldn't do much about. But day-to-day care, I think we did a good job.
And the living conditions of people there were very poor. No fresh water, and a lot of the fresh water that was there was very polluted from insecticides, and the rivers were very, very polluted because of the people washing in the rivers. So those kind of issues, a lot of malnutrition, a lot of violence, against children, a lot of violence against women, which made it, which was one of the very challenging parts of the job.